see it? Does it pop up on your Zoom screen?
Yes.
It did, yep.
So question one, so everyone answer while Najee try to answer this one, and then we'll compare both results and go from there.
Beautiful.
Does it let you submit after the first question?
Yeah, Abdullah, it's prompting us to answer second question too.
Sure, just answer the first one, and then I'll end the poll after.
Okay.
All right, so I mean, this gentleman, he's asymptomatic, but has a polyp. Personally, I mean, since he's asymptomatic, I guess I would just go for a repeat ultrasound in 6 months. That would be my guess. See.
Okay. All right, let's find out what's the right answer.
Sorry, Nishra, just trying. So it didn't show. Did you guys try to answer it?
Yeah.
Yeah, I hit the C. Well, I hit C.
Uh-huh.
And like nothing, like and poll ended, but nothing happened, obviously.
Because it didn't show here either. Like it's not showing anyone. They're saying attendees are viewing questions, but none of it is getting answered. Let's try. Like,
it's not letting you click submit. I think unless we answer all of them, it's not going to let us
answer all 10.
Yeah, I think so.
Can you make it one by one?
The polls, it's like it's one poll for each, and you have to have multiple questions within each poll. That's why.
I mean, you can make one poll and you just end it, and we see the result, and you make another one.
Yes, I guess some people answered all of them because I can see 2 answers on all of them. Anyways, we'll just figure out later.
Okay. All right. So let's go ahead. So the right answer here is removing the gallbladder, because this patient. So it's all about gallbladder polyp here. This guy has an 8 millimeter polyp with some gallstones. So in this case, what you do is, if the polyp size is larger than 1 centimeter, then you automatically remove it. Or if the polyp is of any size, but if there are gallstones, then you also remove it. So that is something to know, because there is increased risk of gallbladder carcinoma with gallbladder polyp, and larger the polyp, more risk for having this polyp being like a malignancy. So these gallbladder polyps are fairly common. 5% of ultrasound will diagnose this. So the only time when you wait for these is when these polyps are less than 1 centimeter. And when there is no gallstones, you can repeat the ultrasound in 6 months. And if there is any increase in size after that, then you remove the gallbladder. All right, Mazid? All right, next one. Do you want me to pick who wants to do this, or? All right, Mahmoud, I see you.
So 65 years old man undergoes screening with ultrasonography for AAA. He has no symptoms. His medical history is unremarkable, and he takes no medications. Vital signs and other findings of the physical exam are normal. On the abdominal ultrasound, the abdominal aorta appears normal. Multiple gallstones smaller than 1 centimeter in size are seen in the gallbladder. The liver has normal echogenicity, and there are no dilated bile ducts. No abnormalities are seen in the gallbladder wall. Which of the following is the most appropriate management of this patient's gallstone disease? Cholecystectomy or ERCP? Repeat ultrasonography in 6 months, or clinical observation? I think clinical observation. He has no symptoms, and gallstones are less than 1 centimeter. So clinical observation for symptoms.
Yes, so you are right. It's clinical observation, because like you said, this patient is asymptomatic and his gallstones is not large enough to get his gallbladder removed, right? And doesn't have any symptoms of biliary colic or anything like that. And in the ultrasound, there was no suggestion showing any porcelain gallbladder or anything like that. So let's go and read up this one. So gallstones are incidentally found. Most of the times, patients don't have any associated symptoms. And if they do not have any symptoms and no complications are seen on imaging, or like I said, there is no clinical symptoms, then no intervention is needed. So, but regarding the size, if the gallstones are larger than 3 centimeters, then it is one of the indication to prophylactically remove the gallbladder. Other indications are, like we just discussed, gallbladder polyps more than 1 centimeters, or polyps with gallstones, or if there is any primary sclerosing cholangitis and polyps, and like we said, gallstones larger than 3 centimeter, and porcelain gallbladder that can be seen on ultrasound, because there is higher risk of gallbladder adenocarcinoma and malignancy associated with porcelain gallbladder. So these are some of the indications where you remove the gallbladder. But for people with no symptoms and no complication detected on the ultrasound, we normally do not remove the gallbladder. So correct answer. All right, let's move forward. Next one.
I'll take it.
Okay.
All right. So a 72-year-old woman is evaluated in the hospital for new onset abdominal pain in the right upper quadrant and fever that developed abruptly on hospital day 5. She was hospitalized 5 days earlier for altered mental status. In the ED, she was found to be confused, hypotensive, tachycardic. She was transferred to the ICU where she was diagnosed and treated for urosepsis. Within 24 hours, she was hemodynamically stable and sepsis syndrome resolved. She also had type 2 diabetes mellitus, hypertension, hyperlipidemia. Her medications include insulin glargine, aspart, lisinopril, atorvastatin, and peptazo. On physical exam, the patient is alert. Temperature is 38.2, so still feverish. Blood pressure is 90/62. Pulse is 110, and respiratory rate of 20. Abdominal examination is notable for tenderness to palpation in the right upper quadrant. A soft palpable mass is felt in this area. Lab shows leukocyte count of 20,000, so high, and serum total bilirubin of 5, also high. Ultrasound showed distended gallbladder with wall thickening, pericholecystic fluid, no gallstone is seen. Bile ducts are normal. Which of the following is the most appropriate next step in management? Cholecystectomy with tube placement, endoscopic retrograde cholangiopancreatography, HIDA, or MRCP. So here the patient is having acallous cholecystitis. I don't think there's any further imaging need to confirm it. So probably cholecystostomy with tube placement.
Mm-hmm.
Yeah.
Abdullah, are you waiting for the answers for the poll?
Abdullah, you're mute.
Abdullah, you are muted.
Sorry, someone called me. But I fixed the poll, so now for each question you can answer. Sorry, I missed the last 1 minute. What happened, Raj?
No, I was just asking, are we waiting for the poll answer, because I saw the questionnaire again.
Yes. Okay, perfect. So it's like we have 18 answers. Perfect.
Yeah. Publish the results, man.
Can we see it?
So you actually get to see who answered wrong and who answered correct, or it's just a percentage?
No, just give me. I mean, I can access that after on, I think, to see exactly who each answered what. But you guys don't see anything, because for me it pops up how many people have answered and what question did they answer.
Oh, so you actually see. Okay.
Yes, let me see. Like, I think now you can see it. Did you see it now? Is it like share the results? No?
Yes, we can see it.
Yeah, we see everything.
Okay, cool.
It
Great.
shows this is like 94% chose this, whatever percent chose this. So yeah.
Yeah.
6%.
Who's on the 6% list?
I'm joking.
We're gonna find out. All right, let's go. Let's move forward. So yeah, the right answer here is cholecystostomy tube placement. The only other thing we could be confused about is cholecystic. If cholecystectomy was one of the options, then you would still choose cholecystostomy tube placement, because the only reason, because this patient is critically sick. She's in the ICU. She is septic. She has a white cell count, and she needs her inflammation to subside before taking out her gallbladder. So she will need to get a cholecystostomy tube placement before that. So like I said, is the tube placement is the most appropriate next step in management in hemodynamically unstable patient. This patient did have, she had features of sepsis. She's critically ill, febrile. So this is the right choice for her. And this will allow some time for us to stabilize her inflammation, and then we can proceed with cholecystectomy. Cholecystectomy would be the right answer in patients with acalculous cholecystitis if they are stable. We know the risk factors for acalculous cholecystitis: major surgeries, diabetes, sepsis, trauma, vasculitis, cardiovascular disease, and patients who are ventilated and are on TPN. So this is something, this is one of the, I think, important board questions for us. So hemodynamically unstable patient with acalculous cholecystitis needs a tube placement. All right, next one. Who wants to take it?
I can take this one.
All right.
62-year-old woman is evaluated in the emergency department for a 12-hour history of fever, dark urine, and abdominal pain in the right upper quadrant. On physical exam, temperature is 39.7. Other vital signs are normal. Her mental status is okay. Sclerosis icterus is noted, and the abdomen is tender to palpation in the right upper quadrant. Hematocrit is 36%. Leukocyte count is 14,000. Platelet is 350,000. ELT is elevated 453. Bilirubin is elevated 3.5. An abdominal ultrasound shows a stone in the common bile duct with intrahepatic biliary dilation. Gallstones are also noted. Antibiotic therapy is initiated. Which of the following is the most appropriate next step in management? Cholecystectomy, endoscopic retrograde pancreatography, MRCP, or percutaneous cholecystotomy. So apparently this lady has fever, abdominal pain, right upper quadrant pain, and jaundice, and she has obstruction, so probably cholangitis. I would go with ERCP B.
Yeah. And 15,
There's an option for E in the polls. Don't pick that.
17 people, 18 people agrees with you, and you have to you're wrong.
All right. Whew. We're better than the MaxApp group, 86% versus 79%. So good job, guys. Okay. So yeah, so we're sort of treating cholangitis with biliary obstruction. So people with cholangitis with evidence of biliary obstruction will need antibiotic therapy, of course, but they will also need decompression, and we do this with ERCP. MRCP is there for diagnosis, but MRCP is not therapeutic. So this is never the right answer when they ask you what is the next step to do. Next step is always decompression with ERCP. You got to go in there and take the stone out. We know about the Charcot triad, fever, abdominal pain, and jaundice, which we saw in this patient. So this is important. First, ERCP, and then you will always remove the gallbladder because this patient has risk of having recurrence of cholangitis if gallstones are present in the gallbladder. So ERCP is the right answer here. Okay. Right. And like the other option with percutaneous cholecystostomy, I mean, it will treat cholecystitis, but it will not decompress your biliary duct because the stones are distal from the gallbladder. So that's never a right answer. Right. Next one.
I can do this.
Oh, okay.
All right. Let me get this. A 36-year-old woman is evaluated 3 days after being hospitalized for gallstone pancreatitis. An abdominal ultrasound showed multiple gallstones in the gallbladder and a normal diameter common bile duct. She was treated with intravenous hydration and pain medication. Over the course of 3 days, she tolerated eating and her pain subsided. On physical exam, vital signs are normal. BMI is 32. Minimal tenderness to palpation is noted on the abdominal examination. All other findings are unremarkable. All laboratory studies have returned to baseline normal values. Which of the following is the most appropriate treatment? A is ERCP, B is laparoscopic cholecystectomy before discharge from the hospital. C is laparoscopic cholecystectomy 4 weeks after discharge from the hospital. D is MR cholangiography pancreatography. E is ursodeoxycholic acid. I would say B.
All right. B, and B is the right answer. 90% people chose B. And see, we're always better. You beat them again, 66% in MaxApp, 90%. Yes. All right. So this is the right answer. Yes. So here is this patient came in with gallstone pancreatitis. If you go back to see the symptoms, she came in with pain. She felt better. And then before discharging, we always have to make sure that gallstone pancreatitis, in case of gallstone pancreatitis, we have to take the gallbladder out before discharge. And this has, there have been multiple studies saying that have showed that same admission cholecystectomy will reduce the rate of future complications, gallstone-related complications. So you do not wait for weeks after discharge. So you remove the gallbladder on the same admission. Others, I mean, there are other options, ERCP, all of those things, they are not the right answer. And we probably guys know why it's not the right answer. So the main point here is, in case of a gallstone pancreatitis, the gallbladder needs to be removed during the same admission in the hospital. All right, next one.
Okay, I can do this one. So this is a 39-year-old woman is evaluated for fatigue, intermittent rectal bleeding, and abdominal pain over the past 2 months. She reports that the bleeding is not accompanied by any anal pain or itching. She has experienced an unintentional 5-pound weight loss since her symptoms started. She has no personal or family history of colon cancer or other cancer. She takes no medications. On physical exam, she's mildly tachycardic. Other vital signs are normal. Her BMI is 22. Abdominal exam reveals mild tenderness in the left lower quadrant with no rebound or guarding. Rectal exam shows no masses. Large friable hemorrhoids are present. Laboratory studies show a hemoglobin level of 10.5 and a serum ferritin level of 5. Which of the following is the most appropriate next step in management? Anoscopy, colonoscopy, flexible sigmoidoscopy, I should know how to say that one, and topical hemorrhoid treatment. So there is no pain, so a topical hemorrhoid treatment is not indicated. This is, if it was a hemorrhoid, it would be internal. Anoscopy is if you know for sure it is going to be a left, like a hemorrhoid. I'm honestly between B and C, but I feel like if you're gonna evaluate a patient, put them through the procedure, why stick with C? So my answer is B. Yep.
Okay, excellent. Okay, B is the right answer. So in this patient who comes in with rectal bleed, but has a significant weight loss, is anemic, is iron deficient, this patient needs a proper colonoscopy.
Right.
So that's the reason why other options are not correct, because we have red flag symptoms in patient. If there is any rectal bleeding with any of the red flag symptoms, then this patient should undergo colonoscopy. I mean, flexible sigmoidoscopy will allow us to examine some part of the colon, but it will not give us detailed like visualization of majority of the colon. So that's not the right answer. So that's the reason why, even though they said that she has large hemorrhoids, and they are trying to trick us into picking up the hemorrhoid treatment. That's not the right answer, because you don't get weight loss and significant anemia associated with hemorrhoids alone. So
Yeah,
Sure.
even the left lower quadrant pain as well, because the flexible sigmoidoscopy could just, you could still visualize the left side of the descending colon, but it's still, like you're saying, with the red flag symptoms and findings, why do that? Yeah.
Absolutely. All right.
Sure. I know this is kind of open-ended question, but what are the indications for flexible sigmoidoscopy?
I think you can do a flexible sigmoidoscopy, in terms of screening. I think there are certain screening guidelines where you can, when patients do not want to do, colonoscopy, then sometimes flexible sigmoidoscopy is done. And I think it can also be done when like past lesions had been identified in the left lower part of the colon, where you need to go in and see them again, or you need, you are doing colonoscopy to, treat them again, where you already have established lesions. Then in those cases, flexible sigmoidoscopy is useful.
Okay.
Monitoring.
And from my Google, sorry.
Oh, sorry, good. When you try to monitor like inflammatory bowel diseases, you can also use flexible sigmoidoscopy.
Yeah, and they're saying here that usually if the prep is not ideal, then they could just use that once they go into the procedure. But and there's a lower risk of perforation with flexible sigmoidoscopy. So if someone's having a flare-up of ulcerative colitis, you might just stick with that just to minimize risk of perforation.
All right, let's do the next one. I probably gave away the answer.
Want to do this one?
Okay. Yeah, I'll do this one.
Okay.
So a 75-year-old man is evaluated after hospitalization for an episode of hematemesis. Upon admission, his INR was 2.5. IV PPIs were initiated and his warfarin was held. Endoscopy showed a large duodenal bulb ulcer and with an inactively bleeding visible vessel. Endoscopic hemostasis was achieved and vital signs have been normal for 24 hours after endoscopy. The patient was, just give me a second. Yeah, so the patient was also hypertensive and with atrial fibrillation, the history of TIA. His daily medications were warfarin, losartan, and metoprolol. On physical exam, vital signs were normal, BMI is 32. Other than irregular heart rhythm, the physical exam is normal. Which of the following is the most appropriate management of the patient's warfarin therapy? So basically this patient, he presents with hematemesis, gets treatment for bulb ulcer.
I'll let you think, Yasser, but there's only 11 people who answered the poll. That's another way to know who's actually focused or not. So answer up, people. If you don't know the answer, choose the most, the closest thing you think that's right.
To be honest, hold warfarin therapy indefinitely would be wrong answer for me. I'm not sure, but I think this would be a wrong answer. I'm not sure, to be honest, so I'll just go with A, but I'm not sure.
Very good guess.
Okay.
And that's the right answer. And I think the main point that they're trying to hammer in here is if the INR is therapeutic or maybe just slightly above therapeutic too, it's always best to resume antithrombotic therapy after GI bleed, immediately after the procedure. That is what they are saying. They're saying that once the GI bleed is under control, anticoagulation should be initiated as soon as possible, most of the times on the same day as the procedure. I think we've seen this like when we take care of our patients, sometimes IR or sometimes even like GI people or surgery, even that they say that we probably would need to hold for 48 hours or so. But in terms of GI bleed, they say if the INR is therapeutic or maybe just just slightly above therapeutic as well, you can start, the anticoagulation as soon as possible.
Is warfarin the best medication though for anticoagulation in a patient who has GI bleed? I guess just in like the past and on firm, I know we've preferred other ones.
Yeah, I think there are other reasons to consider what might be like the best anticoagulation for a patient. But I mean, it's still, it's a hassle like managing warfarin with all those INRs and everything, and it's always fluctuating. But it's an easily reversible agent, and it's been around for a long time, so it's still used. So I don't know if there are any other right answer. Anybody else has any idea about that?
Yeah, there's also part of this question, they already controlled the bleeding, so hemostasis have been achieved. So
Correct.
the problem being solved with the source of bleeding being controlled.
Risk of major bleedings compared to warfarin in general. The most important thing is intracerebral bleeding. That's the major one that the DOACs have shown to reduce bleeding, but in general, all major bleedings are less with DOACs compared to warfarin.
Yeah, and with particular DOACs, there are DOACs I think head-to-head have lower risk of GI bleeding, like I think edoxaban. I forgot what the other one was. But at the same time, if they're high risk for bleeding, you also have to consider, as Nishad was mentioning, like reversal agents that are available. So some of the DOACs are harder to reverse than others. But good point.
All right, let's move on. Next one, who wants to do this?
So you want?
I can do this. 36-year-old man is evaluated in the ER after causing 3 bowel movements of red maroon colored blood. He recently injured his knee playing soccer and has been taking ibuprofen 3 times a day for a week. He has no other relevant medical history and does not smoke or drink alcohol. On examination, he's lightheaded but alert. His blood pressure is 80/60, pulse rate is 126, respiratory rate 12, and saturation 98% on room air. Cardiac examination shows tachycardia. Rectal examination shows maroon colored stool. All other findings are remarkable. Vital signs improve after he is given IV hydration, and lab shows a hemoglobin of 9 upon presentation, and 6 hours later, hemoglobin dropped to 7.4. Okay, so which of the following is the most appropriate test to perform next? A, angiography, B, capsule endoscopy, C, colonoscopy, D, upper endoscopy. So this is a guy that came in with GI bleed and hemodynamically unstable.
It takes NSAIDs.
And takes NSAIDs, that's a risk factor. So, and shows that T is like actively bleeding. So A would not be appropriate, and C is more like a B, capsule endoscopy is more like an outpatient procedure that lives with C and D. I think I would go with D.
With upper GI bleed, that was what you think, right? But why do you think it's maroon colored and not black tarry? From this question, the clinical presentation.
Might be a massive upper GI bleed that causes maroon color instead of melena.
So yeah, D is the right answer. Somebody clicked E, 17% clicked E, so I didn't see that option there.
That's the option if people just want to see the results.
Okay. Yeah, so upper endoscopy is the right answer here because, this patient is young, and in a young patient, GI bleed with hemodynamic instability, it should reflexively come to you to think about upper GI source. So that's because that's been in multiple studies has shown that this is the main cause of bleeding for massive lower GI bleed in terms of in patient. So for this, what you do is you do upper GI endoscopy, preferably done within 24 hours. If it's a variceal bleed, they say do it within 12 hours to control the variceal bleed. but within 24 hours, an upper GI endoscopy needs to be done. And like you said, capsule endoscopy, it will allow us visualization of the small bowel, but first you would always go with upper GI endoscopy, and then a colonoscopy, and then when you cannot see, then you do a capsule endoscopy. So that's how we do it. So yeah, that's correct. This patient had anesthesia used ibuprofen, probably had a bleeding ulcer somewhere. Next one, who wants to take it?
Aisa, do you want to do this one?
Sure. 60-year-old woman is admitted to the hospital with sudden onset cramping abdominal pain of moderate severity in the right lower quadrant, followed several hours later by a bloody bowel movement. She has coronary artery disease. Medications are atorvastatin, metoprolol, sublingual nitroglycerin, and low-dose aspirin. On physical exam, the patient appears comfortable. Pulse rate is 110, BMI 35. Other vitals normal. The abdomen is non-distended with normal bowel sounds. Deep palpation elicits tenderness in the right lower quadrant with no rebound or guarding. CT scan without contrast shows thickening of the ascending colon. Colonoscopy results show a segment of subepithelial hemorrhage, edema, and erythema from the cecum to the hepatic flexure. Which of the following is the most appropriate test to perform next? CT angio, Doppler ultrasonography of mesenteric vessels, MR angio, or selective catheter angiography. So he's having the abdominal pain, sudden onset, tachycardic, other vitals are normal. CT scan showed the thickening of the ascending colon, colonoscopy segment of subepithelial hemorrhage, edema and erythema from the cecum to the hepatic flexure. So she went for a CT without contrast. It seems like Doppler ultrasound.
So what is the diagnosis? What are you thinking here?
I mean, so it is like going for a vascular territory, especially the like the ascending colon with to the hepatic flexure. So about, I guess, the superior mesenteric or something. Not the superior. Can't remember the name, but I would go with something that goes to the vessels. Maybe a selective catheter angiography. Or like maybe if it's less invasive, we can go for like a CT angio. It's like less time and less invasive. That's too extreme and too invasive select.
Perfect thought process, man.
Good thought process, yeah. So yeah, CT angiography is the right answer here. But you thought it well. I mean, you deducted down to the right answer, so it's good. So this patient is having colon ischemia in the ascending colon. So it's a right-sided colon ischemia. So like you said, this is the superior mesenteric artery that supplies here, and there is possibly acute mesenteric ischemia caused by embolism or a thrombosis. So CT angiography is the best next diagnostic modality for this patient because of her presentation alone, because it will allow us to rapidly identify which of the vessel is occluded, to what extent the occlusion has been done, and then you can plan on revascularization. And selective catheter angiography, like you said, it used to be the diagnostic test for diagnosing mesenteric ischemia, but nowadays it's used when we have gotten the vessel from CT angiography, and then you have a revascularization plan with IR or like whoever surgery is, and then you go in there and de-occlude the vessel. So that comes later on. So CT angiography is the first radiographic diagnostic test of choice here. And Doppler ultrasound has its own use, but it's mostly limited to like visualizing like distal vessels, and they said that it's more used for chronic mesenteric ischemia than in acute settings. And MR angiography, it has its own disadvantages. It takes longer to perform, and then sometimes it can overestimate the severity of stenosis, overdiagnose things. So CT angiography is the best answer here.
I just want to add one thing, Nishraj. I think we see this done improperly in the hospital. We skip to the imaging before we do a colonoscopy, and it's done often in the ED. They just get a patient with a GI bleed. I just had one yesterday, and we just jumped to the CT angio, which is not the right step. You should get the colonoscopy first, and then you do the imaging.
That's true. Yeah. So I like you said, ideally our patient had colonoscopy already, so angiography is reasonable in this case. All right, this question now. How much time do we have? We have enough time, right? We got 2 sessions. Is Dr. Hebden doing the next thing or no?
No, he didn't get back to me. We'll probably reschedule his. Nabil, did you do one or not yet?
I did one. I mean, I can do this one again. I can do another one.
I can do one.
Okay.
Your call. I don't care.
You can do this one, Reed. And then maybe tell whoever is in the RCC with you to do the next one.
An 80-year-old male is evaluated in the department after a bowel movement with initial passage of brown soft stool followed by a large volume of red blood. He reports intermittent chills and fevers over the past week. He also has a peripheral vascular disease and cholecystitis. His history includes an aortoiliac aneurysm treated with an aortic bifurcation graft 3 years ago. His medications are atorvastatin, hydrochlorothiazide, losartan, and low-dose aspirin. On physical exam, the patient is comfortable. His temperature is 104. His blood pressure is 108/60. His pulse is 112. His respirations are 18. Cardiopulmonary exam is unremarkable. There is mid-abdominal tenderness to palpation. Rectal examination reveals bright red blood mixed with brown stool. Hemoglobin is 9. Leukocytes are 14 with neutrophilia. Which is the most important test? Test.
All right, Reed, can you let us know what you're thinking, like in terms of diagnosis or what comes to your mind, so that
He reports fevers and chills. He has a fever on interview. He's also tachy, so he's coding for sepsis here. So I'm thinking of an infectious process, maybe.
Yeah, and they also mentioned that he had a aortoiliac aneurysm. He had a aortic graft some 3 years earlier.
Okay.
So they might be giving us a little bit of clue. It might just be like something that's just there for to make us more confused. But do you think there's any association with that?
His light pressures and his tachycardia and his low hemoglobin could be pointing towards a bleed as well. And there's mid-abdominal tenderness to palpation. Is there some type of mesenteric bleed here? I'm going to go with C.
With C?
Yeah.
All right, let's see what's the right answer here, and then we can talk about it further.
So A?
So A is the right answer, but our poll is divided, so this is a little tricky question, but
I was thinking between B and C, and I want to see what it is first. That might be what.
Yeah. So this is a little tricky question, but I think once you go through this question, you will not miss any of these questions in the board. So basically, what it is saying is this patient had a aortoiliac aneurysm and was treated with aortic bifurcation graft, and he had a fever. And now with all this fever and septic picture, he came in with large volume of red blood in like a GI bleed. So basically, what this is pointing us towards is Aortoenteric fistula. So what's happening is he had a graft infection, and it's common that after a graft infection on this sort of patients, there is a chance that a new fistula develops between the aorta and your bowel, and you can end up having large volume of blood loss from your GI tract, and there is a very high mortality associated with this. So the best way to diagnose this is getting a CT with contrast as soon as possible to rule out any fistula that might have been created. So he's having a brisk bleed. He was having brown stools, and then he had a brisk bleed. So that is, a buzzword, a keyword, which can, in a patient with a history of fistula and a graft, that can point you towards this diagnosis. So it's CT with contrast is the diagnostic modality here. Mesenteric angiogram is used, but given because the bleeding here in this sort of in the fistulas can be intermittent, so this is not the best way to do it. And upper GI, you would not see anything with upper GI. And I know you were thinking about mesenteric, you're thinking about small GI, or you would think you're trying to pinpoint the source of bleeding, and you said RBC tagged scan, but this case was a clear-cut aortoenteric fistula, so CT with contrast. All right. All right, let's do the next one.
Anyone, it sounds like Fahad is moving. It's coming from the RCC.
I can do this one.
So
Okay.
72-year-old woman is evaluated after being hospitalized for GI bleeding. She went to the ED after passing a large amount of bright red blood per rectum at home and became lightheaded. She had a second bloody bowel movement in the ED. She is otherwise healthy and takes no medication. Findings on physical examination, including vital signs, are normal. Labs show a hemoglobin level of 9. Which of the following is the most appropriate next step in management? Angiography and arterial embolization, colonoscopy within 8 hours with cleansing enemas, colonoscopy within 24 hours with oral bowel preparation, tagged RBC or transfusion of packed RBC. So it looks like acute GI bleed, no previous history. She became lightheaded, so symptomatic. No past medical history. I'd like to do a colonoscopy as soon as I can. Wait. But large amount of bright red. Actually, I'm thinking between A and B, just because it's a large amount of bright red, maybe, but it doesn't look like. I think I'd go with A, just because it's a large amount bright red and then acute as well.
All right. Do you want to change your answer now?
Yes, I'd say colonoscopy.
Okay. So yeah, so this patient is having a GI bleed, and colonoscopy is the choice here, but it's basically trying to ask us, what sort of colonoscopy do you want to do? Do you want to do a half-baked colonoscopy with 8 hours with a little bit of cleansing enemas, or do you want to do a colonoscopy within the 24 hours, but with proper like bowel regimen and bowel preparation, and get the most out of your colonoscopy? So there have been studies showing that standard oral bowel preparations, a full bowel preparation, and colonoscopy has shown more benefit than colonoscopy done hastily with minimal bowel prep. So bowel prep and full bowel prep and colonoscopy within 24 hours is the right answer in this patient. So did you have questions, Fahad? All right, that's fine. All right, and in this patient, I know her hemoglobin was 9, so we always should have a very restrictive transfusion strategy, and we always transfuse. We know all this. We've done this a lot of times when the hemoglobin is less than 7. So that's what we're gonna do. All right, now, and then you chose A as well at some point. That's not the right answer because, like we discussed, like Nadine was saying, colonoscopy is the initial diagnostic test that we need to do in a patient who comes to the hospital who has hemodynamic, instability with significant lower GI bleed. This is the first test that we do, and then when you see something or you do not see anything, then you go and choose another test. All right.
Nusraj, if she was hemodynamically unstable, even if the hemoglobin is 9, you would transfuse, right?
If she was still continuing to lose blood and you think that she, in practical purposes, I would say yes, I would still do it. But there are multiple questions here in MEXAP as well, saying that like be restrictive in terms of blood transfusion and only transfuse if there are indications, for example, like cardiovascular reasons to transfuse to keep it more than 8. They're saying that it's always good to transfuse when the hemoglobin is 7 or less than 7.
Okay.
Yeah, but I know in the hospital, in the ICU, if the patient is having a massive GI bleed, you always give them blood.
Like hemorrhagic shock and the patient is
Correct. Yeah.
transfuse even if it's because it takes time for the hemoglobin to drop.
Absolutely. Yeah. All right, next one. I think this question will answer that for us. So.
Okay, so a 55-year-old man is evaluated after being hospitalized for epigastric pain of 1 month's duration and melanic stools for over the past 3 days, associated with fatigue. No hematochezia, emesis, chest pain, or shortness of breath. He has osteoarthritis, treated with ibuprofen. He received an IV fluid bolus in the ER. On physical exam, his blood pressure is within normal limits. Other vital signs are normal, no orthostatic changes. Abdominal exam shows epigastric tenderness, otherwise unremarkable. No chronic liver disease signs are seen. Lab studies show hemoglobin of 7.3. Shows upper endoscopy shows a 1.5 centimeter duodenal bulb ulcer with a clean base. Which of the following is the most appropriate resuscitation measure? Transfuse red blood cells to hemoglobin of 8. Transfuse till 9. Transfuse till 10. No transfusion. At this point, his vitals are stable. He's having just fatigue. No shortness of breath or anything else. Yes, I would just still continue just fluid resuscitation, and I don't think there's any reason to transfuse here, and no cardiac risk factors. So.
Absolutely. Yep. So no transfusion.
Who is still picking E?
That might be me, but no, that's not me. All right. So blood transfusion, if patients are hemodynamically stable, like we said, 7 is the cutoff. But there can be liberal transfusions. If, like we discussed, if patient is in hemorrhagic shock and has continual GI bleed, then you will obviously, before you get the next set of labs, I would obviously give them blood. Otherwise, some of the other indications we already know about, like if there are any other cardiovascular indications to keep it above 8, that's the reason. Otherwise, give them IV fluids. If they're hemodynamically stable, then the threshold is always 7. Next one. All right, this might be the last one here, so whoever wants to take it. All right, who's left?
I can take this one.
Oh, okay. Thank you, Osama.
28-year-old man is evaluated after hospitalization for lower GI bleeding 6 weeks earlier. At that time, he was found to have innumerable adenomatous colon polyps during colonoscopy. He underwent total colectomy, and the pathology showed a 2 centimeter adenocarcinoma in the transverse colon. There was no evidence of metastatic disease. Genetic testing confirmed a germline mutation in the adenomatous polyposis E. coli ABC gene, consistent with FAB syndrome. Family history is unremarkable. On physical exam, vital signs are normal. Abdominal exam shows a well-healed scar with no tenderness to palpation. Which of the following is the most appropriate test to perform? So he came with lower GI bleeding that started 6 weeks ago, and he underwent colonoscopy and then total colectomy, and then he was found to have a 2 centimeter adenocarcinoma with the transverse colon, and now he's seen in the clinic, I guess. Okay. Which of the following is the most appropriate test? Barium upper GI series, double balloon enteroscopy, upper endoscopy, no further testing. I think I will go with upper endoscopy because I think these patients might be also at risk of developing polyps in the upper GI tract, in addition to polyps in the lower GI tract.
Yep. Did I miss that one?
Yeah, I think we missed the other one.
Okay. I think I might have missed it. This quick question, I mean, this probably is not a GI bleed question, but it was here. But yeah, I think you probably would do a upper endoscopy on this patient because with this, the patient might have some polyps in his upper GI as well. So you might want to do a upper GI endoscopy in this patient as well. So I think that's the right answer there. So let's move on to the next one. Sorry about this. This came into this lecture, but it was supposed to be only a bleeding lecture. All right, let's do this one.
I'm gonna try Farah. Has Farah answered? Have you answered Farah? I'll try this one.
Sure. So a 75-year-old man is evaluated during a follow-up appointment for a newly diagnosed iron deficiency anemia and stool testing positive for occult blood. He has undergone upper endoscopy and colonoscopy twice with no cause found for his GI bleeding. On physical exam, vital signs and other findings are unremarkable. Laboratory studies show a ferritin level of 6, a hemoglobin of 9.9, and a mean MCV of 78. Which of the following is the most appropriate next step in management? So his ferritin is 6, which is low. Hemoglobin of 9.9. So he has microscopic anemia. Small bowel follow through. I don't think we need that at this time. Capsule endoscopy, I think that's if they're actively bleeding. And he just has iron deficiency anemia.
There is a hint there in the question, but I don't know if you want to pick that. That A looks a little bit darker, but
no, I think I'll go. No, I'm just joking. I'll pick A, even though I wasn't going to. So
yeah, so that's the right answer. This patient had GI bleed. Occult stool testing was positive. Obviously has anemia and already undergone upper endoscopy and colonoscopy twice. So the right answer in this case would be capsule endoscopy. So, capsule endoscopy is a very non-invasive method of visualizing the small bowel. But the downside is it cannot sample any tissues. We cannot treat anything if you find anything. And it cannot be done in patients who have significant dysphagias, who have significant gastroparesis, like bowel obstruction, or patients whom we're not going to do any surgeries. If we find anything, then you would not do a capsule endoscopy on this patient. Otherwise, to find occult bleeding in patients who've undergone both upper and lower GI scopes, capsule endoscopy is the right answer. There is this enteroscopy, push enteroscopy that is normally done. That's basically upper GI endoscopy, but you advance the endoscopy beyond the ligament of trach into the jejunum. So that's very operator dependent, and they said that sometimes it helps us to give us idea about where the source of bleeding, if it's in the upper segments of the small bowel. But capsule endoscopy is always the best way to find it. Okay, I think that's